Good morning, everyone. This is Patrick Jones, your facilitator for this and prior Leadership Council meetings of Greater Columbia's ACH. And I just wanted to let you know that I'd like to wait just a couple more minutes to see if we can get some of the folks who we think will be attending dialed in, and then we'll get started right away because we've got, as usual, a pretty full agenda. So stay tuned. Well, good morning again. This is Patrick Jones, and I think it's the appropriate time to get started. We've got close to 50 people on the line, which was our expectation, and maybe that expectation will be exceeded here shortly. On behalf of the Greater Columbia ACH team, I would like to welcome you to the first meeting of 2021 and the start of our 7th year in holding these Leadership Council meetings. I'm not certain, but my hunch is that we are one of the very few of the 9 ACH organizations that has continued with something like a Leadership Council. So I'm happy we can be together and participate and share knowledge, which is really the essence of these meetings. If we were in a person-to-person context, I would probably go around the room and ask folks for their at least one of their New Year's resolutions, but we don't have the time to do that here online, and so we'll hold that thought for later on. As you can see or have seen, I hope, from the agenda, we are going to be looking both reflectively, that is in the past, and prospectively towards the future. That's really the essence of our meeting today. The look back is going to start with a reflection by some of the ACH team. And then we've asked three organizations from the practice transformation effort to share some of their thoughts about what 2020 has meant for their team. And then it's always important to get a sense of what the compass might look like. And so after the break, we will look at our 2021 goals as the team has been able to articulate them so far. And then we want to wrap up by asking you what you would like to see covered in terms of topics in healthcare reform that affects this 9-county region for the rest of the year. So with that, I'm going to turn it over to Carol. I think you start, right, Carol?
I do, Patrick. Thank you so much for getting us started on this winter January day. Reflections is a really good topic because I have actually some kind of sad news to relate to all of you. Lauren Noble is leaving Greater Columbia ACH in order to join her family business, and we're excited for Lauren about this new career step, but then we're also really, really sad because Lauren has been such an integral part of our Greater Columbia ACH team. She has really spearheaded a lot of things that we're going to be talking about today. As you might recall, she took over the reins from Ashleen Fernandez actually in March of 2018. So she's been with us almost, 3 full years. So she's really helped us, grow from the toddler to teenage to now the young adult stage. I don't know how we're going to function without her, but we're going to try to manage. One thing about Lauren that I want to say is that I have never heard her say one unkind word about anybody, which is pretty remarkable. She always has such a positive attitude and just an amazing work ethic. I'm just going to highlight some of her accomplishments. You're going to hear about our second annual report today. She spearheaded that first one last year, so we're going to carry that forward as a tradition with Greater Columbia. She single-handedly organized and delivered our radio telethon that raised over $14,000 that went to purchase care packages for seniors living in assisted living facilities in Benton and Franklin counties. She oversaw and organized the masking campaigns in Benton, Franklin, and Yakima counties. One was targeting the Spanish-speaking population. The latest masking campaign actually featured community leaders from Yakima, including Carlos Olivares, Arlen Washings from the Yakima Nation, Representative Chris Corey, Matthew Murray, who's Yakima's chief of police, and one of our own board members, Madeline Carlson. She oversaw the test marketing site, helped get that launched in Benton and Franklin counties. And as we know, that's been a tremendous success. In December, there were over 700 people that were driving through that site to get tested for COVID every day. She also oversaw our branding, a change in branding. You might recall that we used to be the bright orange, and now we're the more complementary professional navy blue logo. I could go on and on. Unfortunately, we don't have time. So what I'd like for everybody to do, if you wouldn't mind, if you feel so inclined, just put your note of thanks and note of congratulations in the chat box so we can preserve those and Lauren can read over those at her leisure. But anyway, it's just with sadness that we say goodbye to Lauren and wish her well. Thanks, Patrick.
Okay, so we now would like to, as people are giving some of their thoughts to our hardworking Lauren, we'd like to just start with the team's reflection on 2020. And I don't know, Wes or Sam, are you going to start or is Carol going to start?
That would be Lauren.
That would be Lauren starting. Well.
Yeah.
Yes, I will start. Thank you so much, Carol, for those kind words. It's really sweet. And thank you to everyone in responding and putting some comments in the chat box. It's very bittersweet. I told Carol that I will still be stalking the Facebook page and the website so I can keep up to date with GCACH and what we turn into in the future. So thank you again to everyone. That's really sweet. So the annual report, this is a draft form of the annual report. This is not finalized. This is actually our second draft, but we're really excited to share it with you today. It's a little bit different format this time around as opposed to our 2019 annual report. If many of you recall, I'm not sure, our 2019 annual report was kind of a two-sided trifold. It was really, intended to mail out to our stakeholders, elected officials, and this time around, I think that we are planning on instead sending it via email, and so we wanted a friendly format for that electronic distribution. However, we can print it as well. It's 8 pages, so it will be a little bit longer if we do print it, which I'm sure we will have a couple, but just wanted to share with you that that's why we have a different format for the 2020 annual report. So as you can see on our cover photo, last year we had received some feedback that they wanted to see more about our work over the year. We just had one cover photo last year. So this year we encompassed several more photos to really highlight our work over the year. So you can see, a lot of masked individuals. I think that's a really great representation of 2020. You can see that, there's masked individuals in front of boxes, so that really highlights our mask distribution. We have a masked individual that was highlighted in our masking campaign, a masked family that was also highlighted in our masking communications campaign. We have master gardeners who gave us a donation for a skilled nursing facility project, and then we have Carol with the Yakima Nation Tribal School. So a lot of great pictures highlighting our work from 2020. Next page, please, Chelsea. And then, of course, we wanted to, open our annual report in this first page and how we addressed COVID-19 over 2020. So we talked about our telehealth fund and how we provided $276,000 to 51 organizations to implement telehealth. So, that really, that funding went towards addressing barriers like maybe not having webcams or not having laptops or the software needed to implement telehealth, which was, really needed in 2020 as, several individuals were not able to go in to see their providers. Personal protective equipment distribution. We joined that distribution, which was really exciting. We distributed 2 million items, including gloves, gowns, face shields, masks, goggles, to over 100 organizations throughout the Greater Columbia region. So this distribution was really received in 2 separate shipments. Our most recent shipment, we really partnered with our local health improvement network. So thank you to those links that helped us distribute the masks and other equipment where needed throughout our region. Next is our assisted living facility project. This was a really fun one. We were able to partner with New America Credit Union to shine through for seniors, and we hosted a radiothon and a telethon. We were able to raise over $14,000 to put together those care packages in our HEROES program for Ben Franklin County assisted living facility residents. So that was really well received. We also have some photos throughout our annual report that are from this project. Skilled nursing facility project, this one's very similar to the assisted living facility project. However, we did not receive donations for this one. This one came strictly from Greater Columbia ACH funds when we set aside over $19,000 again to organize those themed care packages, and these were residents throughout the Greater Columbia region for this project. COVID-19 test site marketing, this one is probably our most recent COVID-19 endeavor, and so we partnered with Benton Franklin Health District to stand up that test site, as well as many other community partners, and really tackle that marketing to make sure that Benton Franklin County residents know where to find that test site. It was very successful. The test site grew from administering 83 tests on the first day to 181 on day 5, and now exceeds 700 tests per day. So very successful, really exciting to see that community need met. And then lastly, certainly not least, is our Second Harvest funding. We donated $300,000 to Second Harvest to benefit the 96 food banks within the Greater Columbia region. We held our first ever virtual press conference, and it was successful. It was only 30 minutes, but we had a lot of media present, so it was really exciting.
Lauren?
Yep.
So just to highlight the effectiveness of the test site marketing campaign, which in large part you organized, the Tri-City Herald today reported that the National Guard site, which moved from Pasco to Kennewick, within a recent 2-week time period, had done a little over 800 tests. The COVID test site at CBC, which we did marketing for in that same time period, did more than 8,700 tests. So it really speaks to the necessity and the effectiveness of the marketing that we put together.
Thanks, Wes. We can go to that next page, please, Chelsea. Sorry, I might have taken a little bit longer, but Sam, would you like to talk about the Greater Columbia Cares model really quick?
Lauren, Sam might not be available. I think that she might have had a doctor's appointment. Wes, would you mind covering the Greater Columbia Cares model?
So this particular slide simply highlights, presents an overview of the Greater Columbia Cares model, which is built up off of several evidence-based practices and curriculums. It utilizes the Comprehensive Primary Care Initiative, which was a CMS initiative in innovation, which proved to be very effective. It also incorporates the 6 building blocks, which is sort of like the chronic care model, but focused towards individuals with substance use disorder. It includes aspects of the patient-centered medical home, which receives accreditation by several national organizations. We've also incorporated Workforce for the 21st Century, which is kind of an overall theme that has focused on behavioral health integration and behavioral health internships, and soon will include community health workers. It also includes aspects of the Robert Wood Johnson Foundation. And the core curriculum itself for our navigators, which is led by Sam, includes standard evidence-based curriculums from AHRQ, the Institute for Healthcare Improvement, and the Safety Net Medical Home curriculum. All of those have been supported and endorsed by the McCall Institute, which was the originator for the chronic care model. So this is a very robust, fully built out practice transformation curriculum that's embodied in the practice transformation toolkit, which we put together and which we implement with our partnering provider organizations.
Thanks, Wes. The next page talks about the practice transformation cohorts. As you may know, we have 3 cohorts that are comprised of different providers across our 9-county region. So in this page, we talk about the provider type. So you can read that we have, hospitals, clinics, behavioral health, federally qualified health centers, skilled nursing facilities, a couple of school-based clinics, dental, palliative care, and the list goes on. We have been very inclusive about spreading the wealth of our Greater Columbia Cares model. I think the story to tell on this page is really that we've been able to distribute $36.8 million in incentives to our providers for practice transformation efforts. This is hard work. We recognize that and want to reward our providers for taking that leap of faith in the Greater Columbia Cares model to help improve their practices and patient care. We have over 86 sites that our practice transformation team goes out to or meets with over the phone this past year. And additionally, we also have a grant with the Washington Rural Health Collaborative, and we're working with 6 different sites in order to implement some of the practice transformation changes that we apply in the Greater Columbia Cares model. Next page. I don't know if Martine is able to talk about our practice transformation success stories. Laurel or Brittany, do you guys want to talk about some of the practice transformation success stories?
This is Laurel. I can. I'm familiar with Chaplaincy Behavioral Health. They've done just a terrific job during the year of 2020. They have implemented risk stratification on all their clients and grouped them from the highest to lowest. They now provide care management to 100% of their patients in the highest risk stratum, and their clinical quality measures are tracked, monitored for improvement, and reported back to the clinicians to guide and inform care. Also in the Tri-State Memorial, went to having no patient registries or lists of patients to be sure they're following up with in their primary care and behavioral health sites in their first year, and to now having registries and working towards building more to include additional diseases and risk statistics. We're supporting primary care behavioral health integration. GCACH dedicated $850,000 through the Behavioral Health Internship Fund to support 19 organizations in supplementing their behavioral health workforce through 42 behavioral health internships. And then I could speak to the opioid resource networks, but maybe that would be more appropriate for Diane.
Yes,
Sure.
that would be great.
So we created 4 opioid resource networks, and they had a total, between all 4 of them last year, there was a total of 322 new inductions and 200 that remained in treatment for 30 to 90 days. And I think I'm the next slide as well. So for the social determinants of health, we actually had the local health improvement networks, as you all are aware, where we've had them present at the leadership councils many times. We dedicated $1.5 million that was distributed across the region to address care, housing, food insecurities, behavioral health, youth suicide, employment, access to internet, and education. And there's the van there that was purchased as an example of well-used funding. And we also did the pilot program for our building community resilience, addressing the adverse childhood experiences. And we created an English advertisements as well as Spanish advertisements. We actually have a new community resilience campaign this year, and that's going to be for 2021 that addresses COVID and the behavioral impacts that it has had. But this has also been building community resilience is big on our radar this year.
Thanks, Diane.
Mm-hmm.
I think Wes is going to talk about pay for performance.
So I'm not going to go into a whole lot of detail around this area. And the calculation that's required to determine our performance and our effectiveness in this area is kind of complicated. But through the 2017-2019 time period, the region that we serve and all its Medicaid clients was assessed through Healthcare Authority based upon these measures that relate to access to care, institutional utilization, substance use disorder, mental health treatment, penetration, and more. Based on their assessment of that time period and some performance targets that were assigned to us, we've estimated that we will be eligible for about 55% of pay for performance incentives which is actually a very positive thing. On some of these measures, we actually achieved 100%. On a couple of measures, we actually went in the negative direction, which actually has more to do with system effects than practice transformation. So we expect payment for that 55% achievement to be earned and received by us likely within the spring of this year.
Thanks, Wes. And Chelsea, you're going to cover the last page?
That is correct. So as you can see, we have 17 different sectors on our board, so represented by 17 different professionals through education, hospital, healthcare providers, workforce, and this really lends itself to having that cross-pollination of our decision-making and our strategies and everything that guides us in our great work. We've held several meetings over the past year, including our Leadership Council, workforce and committees, our Budget and Funds Flow Committee. We've had our Learning Collaborative. So a ton of great meetings where we're trying to disperse information from various subject matter experts, as well as include all of you great attendees that we have today. And that included over 400 attendees. So we hope to keep including these wonderful meetings this upcoming year.
Thank you, Chelsea. So that is a look at our 2020 annual report, and thank you for indulging in some of this reflection.
This is Patrick. Before we shove on, I just wanted to ask whether there's any quick questions of the material you just saw. It was obviously a lot crammed into 10 minutes, but if you did have a quick question, go ahead and pose it now. Nothing in the chat box yet. All right. Well, there'll be other opportunities if you wanted to pose questions to the ACH team as we go on. Right after the break, we'll be looking at 2021 goals, and perhaps you might have some ideas then to ask of the team. Now it's the time to actually hear
Patrick?
from, yes.
There was a question in the chat box about what will the final date be for the final report? The date be for the final report?
Yes, I do see that. Sorry. And
I guess I could
can
answer that.
Wes.
Yeah, thank you,
Go
Lauren.
ahead, Carol.
No, go ahead, Lauren.
Oh, I was going to say we are presenting it to our board of directors this afternoon. So depending on how many suggested changes they have, we're hoping that we should have it finalized by next week.
Okay, so quite soon. And then, Lauren, you mentioned it will be mailed, or how will it be distributed so people can get a sense throughout the region of what's going on?
We plan to mainly distribute via email, so through our distribution list through MailChimp, and then we'll definitely have it on our website as well, but we will plan to print some copies. If anyone's interested in receiving some, please let us know and we'd be happy to send you some.
Okay.
There's also a second question from Catherine McDaniel that is directed towards the navigators. And the question is, can we share the risk stratification method used by chaplaincy?
Hi, this is Laurel. Catherine, I can get back to you offline or perhaps connect you with chaplaincy behavioral health. I don't know if Teresa Avalos is on the line with us. Hearing not, I will respond to you individually with that information.
Okay. Well, just to stay on track, folks, let's shove on and hear from the three of the leaders of the practice transformation efforts. The first one, as you can see, that's up on the screen is from the Garden Village. And then we'll hear from Quality Behavioral Health, and then finally from Kittitas Valley Health. So Haley, I imagine you are on, I saw you earlier, or saw your name earlier. So I'll let you take it away with Chelsea at the driver's wheel.
Hi, yes, good morning. I hope everyone can hear me over my mask. I'm happy to be presenting on behalf of Garden Village, and the presentation will kind of go in order of these questions. So let's just kind of dive right in and get started. Next slide. So this year we've had a lot of accomplishments, and especially due to the pandemic, a lot of them have been technology-based. Funding provided by Practice Transformation allowed Garden Village to begin implementation of our first electronic health record, point-click care. We were one of the few facilities left in the county that had all paper charting. So this was a really big step in moving forward with the care we provide on a day-to-day basis. We were also able to begin use of TELS, which is a technology-based system that helps with maintenance tasks on the go. The system helps monitor work orders, repair histories, warranties, and has really helped us make better business decisions in the long run with the products we use. Another electronic system we've used is Relias. It is a training platform that has helped us stay on track with our staff trainings, their understanding of what we do every day, of the tasks they're responsible for, and has kept us really on track with certain long-term care regulations. And during the pandemic, again, with electronic communications, we started to communicate with families via email for the most part, and with staff as well. We would communicate with them over our payroll system to really just keep everybody up to date as changes took place in real time. There were a lot of changes, so every time something happened, we were sending out communications to everybody to make sure everyone was aware of what was going on. And telehealth became a practice that we began. Considering the pandemic, we couldn't send our residents out into the community, so a lot of our appointments were telehealth based, and that was something that we were able to do also with guardianship hearings and also in general for our residents to see their families. Next slide. So there were a lot of barriers throughout 2020 with the pandemic. The main barriers we experienced had to do with staffing resources. So we used to offer training classes for individuals to obtain their NAC license. And because of COVID, those training classes were suspended. In addition, there were restrictions placed on nurses who worked in other facilities or hospitals. They weren't able to do that. So for a long time, our charge nurses, a number of our charge nurses weren't able to enter the building for months. So this put a huge strain on our staffing capabilities, and for quite a while, we had very thin staffing on the floor. Another barrier was and kind of continues to be limited entrance into the building. We have one entrance and one exit, so everyone that comes into the building has to be screened every day per shift. And we've had to have deliveries dropped off in the alley. They can't come in the building. And a big impact for our residents were that visitors can't come in and see them. They weren't able to see their loved ones in person. Our activities were suspended, and all of our dining rooms have been closed for almost a year. So that's been a really big barrier to get over this entire time. And it continues to be a barrier that we address on a daily basis. Admissions is a big piece. It's a barrier that we continue to work on as well. With county rates as they increase, we're not able to admit as freely and without restrictions that are added on top of current regulations required. So keeping our census up is very difficult. Overall, really the main barrier was just having a total commitment of staff resources required to navigate our day-to-day operations. Next slide. we've received a lot of help this year from you, and starting with funding that we were provided for 7 of our MACs to be trained, which helped provide great support, and it compensated for those staffing issues that we experienced by the pandemic. Another help included activity supplies and tablets that were provided. With residents being isolated per requirements, they were isolated to their rooms all the time, and they still are. They are at risk of increased depression, loneliness, and just an overall decline in their well-being. So the supplies that were provided gave residents kind of a beach-themed experience, and tablets were also provided to help with just kind of everyday one-to-one activities and interaction with families. The tablets that were provided have also helped our staff on a daily basis. Staff are able to take the tablets with them on the go. They can chart as they're providing cares, which helps gain more accurate charting at the same time instead of waiting till the end of the shift to chart their interactions with people. Next slide. Some of the top progress success stories for us in practice transformation includes compliance improvements with our new EHR. A surveyor had recently expressed to us that although Garden Village has always been very person-centered with our care planning, the EHR had really helped us enhance every resident's individuality and has helped in reducing survey deficiencies. So that was a big compliment to receive from a state surveyor, something that we really hold a lot of pride in. And another success that is more visible to residents specifically was a new van provided with grant funds. Next slide. So this is our old van. It is about 20 years old, and we had been using it for a while. It had no heater, no working air conditioner, and at one point the brakes became a little sensitive. So we actually had to stop using this van for safety reasons, of course, and it just provided a miserable experience for our residents going to appointments for a while. So we had to stop using that, and for a while it was really difficult to schedule any appointments in general and transporting residents who maybe couldn't go in a personal car. Next slide. This is the new van, which has a working heater and a working air conditioner, and it has been much easier for staff to transfer residents in and out of the van. The residents have made statements of how much more comfortable it is, and it has really made it more of a smooth experience for residents as they're coming and going from the facility. And it is something that has made a big difference for the residents specifically. So this was a really big impact for us. And again, we want to say thank you for the van because it has helped our residents tremendously. Next slide. Another success is when Practice Transformation provided those beach vacation packages that I had mentioned earlier. These packages were for all of our residents, and they had little sand buckets and little beach balls. And it really made a difference to our residents that day. And not only did our residents enjoy the day and the packages, but it really got our staff involved and helped lift morale as a whole for the entire building. Staff wore grass skirts. They had made a photo booth to walk around and take pictures, and they handed out Hawaiian kind of themed drinks. And the pictures that were taken, we were able to send to our residents' families, which was great for them to see that their loved ones are smiling, their dad is having a good time, and they're getting through this. So that was a really big success for us. In addition, funding through the grant also allowed us to hire a new role in our facility, which is the Education and Compliance Officer. She is someone who has been with Garden Village for about 4 years. And because of the grant, she's been able to help improve training for our direct care staff on the floor. She's helped hire and retain employees and assist with admissions and really just improve our compliance for all staff as a whole. Next slide. So you'll see here on the graph that the blue represents the number of times we were paid a visit by a state surveyor. The red shows how many of those visits resulted in a result of no findings, no deficiencies. And green shows the amount of citations which we received, which, as you can see in 2020, and especially during the pandemic, we received none. Now, knock on wood, we're not going to jinx ourselves here, but a lot of this success is a result of hard work put in by our compliance director and really the focused support that she provides to all of our staff. Next slide. Continued progress that we have experienced this year with Greater Columbia ACH funding has allowed us to capture more accuracy in the services we provide to our residents. So we're able to have a monthly review and training with a consultant who used to only see us once a year. So with her help every single month, she has helped our staff report data more accurately on certain assessments, which results in a better case mix reimbursement. So due to this, we've had a $450,000 annual reimbursement improvement in the last 6 months of 2020. This is just over about 4% increase in our reimbursement from the first half of 2020, which is significant. And as mentioned previously, with grant funds, we were able to train those 7 current NAC staff to obtain their MAC license. This was one of the more important successes we were able to accomplish, being that this happened before the pandemic was even known of. So as soon as COVID became an issue, our new MACs were able to provide great relief when the pandemic started. In being that staffing 2 registered nurses on night shift proved to be very difficult to accomplish just due to a shortage of RNs. And the alternative way to fix that was to have 1 licensed nurse and 1 MAC on our night shift, which has shown that it works and it gets our staff through the night and our residents are taken care of. Our new MACs also help our nurse case managers with resident treatments and resident cares, as well as they assist with COVID testing for all of our residents and staff. The training for these staff really made it possible for Garden Village to continue operations on a day-to-day basis. Without them, we would have struggled much more than we probably did. Next slide. So in this graph, as you can see, in 2020, since working with practice transformation, our case mix score has increased significantly compared to the years prior. So with the case mix score, it reflects the resources predicted to provide care to a resident. So the higher the case mix weight, the greater the resource requirements for the resident. So in seeing that in 2020, that case mix had increased, it really allows us to provide better care for our residents and improve their quality of life, which is our main priority every day. Next slide. In the end, Garden Village really wouldn't have accomplished a lot of these changes without the support of GCACH and practice transformation. We're really appreciative of all of your help and support in better serving our residents and community as a whole. And we continue to look forward to working with you and see how many more accomplishments we can make. That kind of concludes my presentation. So I will answer any questions to the best of my ability.
We've got a couple minutes for questions, folks. If you would like to pose any to Haley, this will be the one sort of practice transformation story from a skilled nursing facility. So it's an opportunity to see how practice transformation works in that area of care.
So this is Wes. I'd just like to make a comment. First of all, Haley, that was a fantastic presentation. It's really worth considering and understanding that the patient-centered medical home model, which we've implemented through the GCCM, originally was meant for almost exclusively primary care. So in the third cohort, when we extended it to nursing facilities, it was really an experiment to see whether or not it would work. It was a bit of an innovation on our part, and to be honest, it's turned out to be a great success. In Garden Village, we're just so overjoyed to see all the positive outcomes that have come through with your hard work.
Thank you.
Anybody else like to comment or pose a question to Haley?
This is Suzanne Swagner from the Healthcare Authority. Thank you for having me today.
Okay.
I just want to follow on Wes's comment. Haley, this was a fabulous presentation. It's very good for us at the Healthcare Authority to see the number of different kinds of settings that you at Greater Columbia are innovatively working in, make an impact in the community, and to really look at sort of the continuum of care that people are in. So I really appreciated hearing how you're doing this work and how you've adapted the tools and processes to fit your needs. So thank you very much. It's long-term care is definitely an area of interest in system transformation as we move forward because of all that you have done to work so hard in such a tough time with limited resources to make care positive for your members. And we know that, and we're looking at how we can take a look at that and see what kinds of system innovations we can do to support you. Wes, I have one follow-up question. We're working internally on using MEHAF scores and thinking about what MEHAF scores do. Have you guys talked about how those MEHAFs, which is really the only tool at this point we have, currently reflect the variety of settings you're using and I don't expect you to have an answer now, but what I'd like to do is suggest might be a nice area of dialogue for us to talk about how to support you in getting those scores to a place where it illustrates well the good work you're doing, especially the good work your provider partners are doing, since they're doing the really hard lift with your coaching.
You know,
I just want to introduce that concept of how we might use these tools that aren't necessarily, as you put it really nicely, created for the alternative settings to help us understand the impacts.
Suzanne, thank you very much. I'll make a comment and then open it up for Carol and the navigators. So all our practice transformation organizations use not only the MEHAF, but also the PCMH assessment tool. So they're kind of double whammied with pre-assessments and then an annual review of sort of an interim assessment as there's really never any post-assessment. We are going to be undertaking an analysis to show changes across those assessment tools, measure by measure, likely stratified by the different types of organization, including skilled nursing facilities. So once we get into that analysis, I have a feeling that we're going to learn a lot about the progress organizations have made, the progress that different types of organizations have made, and the effectiveness of our model. So I would say stay tuned, Suzanne. More will be coming out. And again, I'll let Carol and the navigators add to that.
And Suzanne, I don't really have a lot to add, and I know we're kind of cramped for time this morning, so maybe this would be a better offline conversation to have, and then we can allow Danica and Dr. Martin to get onto their presentations.
Absolutely. I think that that's kind of where I wanted to go, was just to indicate that this is a rich area for discussion, and I knew that you guys would be thinking about that. So let's kind of put it in our thinking caps. And I'm thinking about it from a workforce perspective also, how we can learn what to do better with this model. You guys are leading the way. Thank you for letting me comment.
This is Laurel, working with Garden Village as their practice transformation navigator. And of note in regards to this particular facility is how wonderfully that they integrate behavioral health and the primary care aspects that are touched upon in the MEHAF assessment. I don't know if, Suzanne, if you had heard how they really do have the focus of incorporating the behavioral health aspects and assessments. They do PHQ-9s regularly on all of their patients throughout their organization. So that question is a good one. And I don't know, Haley, if you had anything to add in regards to how your facility addresses both of those aspects of care.
Yeah, so I mean, Garden Village is a very unique skilled nursing for sure. We definitely focus on behavioral health and the primary care of the behaviors that we're seeing, in the fact that a lot of times medical complexities can cause certain behavioral situations. So we address the whole person. We really look at every single thing that could be going on that may cause somebody to escalate or have an outburst or maybe even decline in a certain way. We really have dedicated staff that treat the person and not necessarily the diagnosis. So we are a very patient, resident focused facility here. And we really just look at every single thing that's going on and treat everybody the best we can.
Thank you to both of you. Those are rich areas for us to talk about in our offline discussion.
Thank you.
All right, Shell, that was a rich discussion, and thanks everyone for chiming in. I've just been notified that Danica has to leave real soon. So Danica, Gwynne, that was a nice segue into to your part in your organization's part in practice transformation. And we'll just leave these questions up here. And I guess you're going to talk to them and not give us a PowerPoint presentation. Is that correct? Danica, are you there? Or are you there but muted?
Can you hear me okay?
Yes, we can.
Okay, yes. My name is Danica Gwynne. I'm the clinical director at Quality Behavioral Health. We are a community health organization. We do multiple things related to helping people. We have housing programs here. We have a community sexual assault program. We provide behavioral health services, mental health, substance use disorder treatment, housing support, anger management, and supported employment and housing, just to name a few. We were very excited to be a part of Practice Transformation. I think one of the biggest accomplishments it brought to our agency is really turning things back to looking at the clinical aspects of the work we do with clients. So much of our work can be sidelined by requirements and meeting specific goals, et cetera. And this really brought back the clinical aspect of what we're here for. So that was exciting. One of the biggest things that we were able to do when we started out in our Cohort 1 project is hire on Whitney, who is on here today, Whitney Bone. She was hired to head up all of our practice transformation projects as our coordinator and specialist. She worked with Martin quite a bit, and she's really been the key to making this happen. And I've asked her to give me information to share with you today to help answer some of these questions. So a lot of this info comes from her as well, as she's been in the very middle of all of this. So we were able to hire Whitney. From there, we were able to take a snapshot of all of our clients. We were able to screen them through specific screeners we chose and able to risk stratify them to identify those individuals who were at highest risk to possibly be hospitalized, be in crisis. And from there, Whitney began doing intensive case management services. We created a care team, which included our clinical managers, Whitney, those who were involved with clients' care, and that included our doctor and our nurse. And we have met weekly, very continuously. Every week we come together to focus on the efforts of how we can help clients who are in the highest risk at our agency. So that ability has really allowed us to increase clinical decision making. We sent staff off and continue to send staff off to get evidence-based training for all of our clinical staff, which has been a huge boost. in the work they do with clients. The other key components were really allowing clients to be in control of their own health. That's one of the things Whitney talks about a lot, is the empowerment for clients to improve their own healthcare needs and have a consistent person in their life to reach those healthcare goals. And from there, what we're seeing is their risk levels are dropping as we continually every 3 months screen for their risk level. We are seeing results from the care team efforts, from the intensive case management efforts that are provided. People are identifying barriers in health. Whitney is working with them in a shared care plan, and they are knocking goals off week by week. And that has empowered clients, and it's showing in when we rescreen them, depression levels, stress levels, anxiety levels, medications that they're on, everything is really taking a good progress for our clients. Some of the barriers we've faced in our project is just engagement, and that is something that we're continuously looking at. It can be sometimes difficult, especially with COVID, to get engagement. Even yesterday, as we met with Martin, we came up with a different idea about how we continually get to see more and more people and work with them intensely through case management. In our second cohort project, this really allowed us to actually do some construction to open up a room in our new location to bring telepsych on board. We were able to hire on a telepsych provider to increase medication management for clients, which hand in hand allows less clients to be in crisis because they have medication options. We were able to hire a medical assistant to take on some more of that work that would be created with med management. We were able to get our doctor, the MAT waiver through the funding that we received. We were able to support a summer youth program that has a focus of connecting youth to health referrals, getting them to doctors, etc. And because of the practice transformation work of not only us, but those who were chosen in different cohorts in our community, for example, the Chaz Dental Clinic, we now have a dental form that we have integrated into our intake assessment so that we can ensure that when not only is someone being screened for mental health, substance use, all of the different things they could be helped with, getting a PCP, but now we are really pushing for them to get that pre-dental work before it becomes an emergency. We also were able to kind of start our own mock cohort with other funding from other providers. We're following the same kind of tracking system for clients in our Garfield County office, and really just trying to expand on practice transformation for all locations we have in any way we can, and wrapping around our care team with that. I think that how has this helped our organization, or how did Greater Columbia help? I think the biggest thing for me was their flexibility with working with us, flexibility in being creative with ideas, thinking of things that nobody has allowed us to do, and we get to try them out here, and they're showing success. The close work and communication with our practice transformation navigator has been very essential. And then I would say, you know, the biggest thing we've always had to remind ourselves too is the reality that clients or patients really drive what's going to happen, and ensuring that our ideas and beliefs don't push people to get the results we want, but rather the results they want in their care. And we have to keep that in mind. To kind of wrap up with one of the success stories, as Whitney uses the AIMS model of care, and we work through kind of our brainstorming identification of barriers and health needs that each client has, and we make out their shared care plans, and we risk stratify those scores. We have an example that Whitney's provided. We had a client come into our practice transformation program this past quarter. They had struggled with many barriers. They had very low confidence, very low self-esteem and insight, and extremely anxious. The client participated in counseling and case management services to work on their treatment goals and their shared care plan, to knock down those barriers and find the appropriate pathways to get the care they needed. The client was not able to articulate well as to what she wanted to work on at first, but after meeting with the case manager and the care team, she was able to identify needs. Those were put into the care plan. The client began engaging more and more over the course of 3 months and was able to meet two out of three of her shared care plan goals. And she got rid of most of her barriers that she'd been up against with her care. She was able to speak for herself, and her risk quality metrics decreased. Clients' relationships improved with her family members and natural supports, and she was able to seek out a new doctor by herself, whereas in the past she would be too anxious and overwhelmed to even think about doing that. She was rescreened after 3 months. Her scores decreased from 49 points, moving her from the top 10 percentile of highest risk to the 20th percentile. Her number of meds decreased from 8 to 7. Her depression score decreased 12 points. Her anxiety score decreased 10 points. Her stress score decreased 14 points. And her trauma scale upon completing had decreased by 9 points. Her level of risk rating by her clinician went from a 6 to a 3. Across the board, her counselor states she is doing better than she ever has been before, and she continues to work in the practice transformation program. Overall, we want to thank Practice Transformation. We hope the Healthcare Authority hears and understands the importance of the work being done here, and we're excited to see where this takes us. This is really just the beginning for us. We're excited to build on this program and make it bigger and bigger each year.
Thank you, Danica. That was inspiring report. Any quick questions of what's gone on at Quality Behavioral Health, or in just a couple minutes? Anything in the chat box coming up here?
So this is Wes again. I just want to comment and applaud Danica and QBH. You know, at the very beginning of this process, all the organizations that were part of the behavioral health organization, the previous BHO, personally, I think there was some skepticism about the role that we had in all this work. And since this time, QBH has really embraced this model, and they've just been doing some incredible things and really scaling this up. And the outcomes that Danica talks about really speaks to that. So we just want to applaud the great work that QBH is doing.
There you go. Any comments from the practice transformation navigators on the line?
This is Laurel. I know Martine would have some. He's not on the line presently, but I know he just is so appreciative of all the work and that Quality Behavioral Health is doing. Thank you.
Okay. Okay. Well,
Can you hear me, Patrick?
yes.
Oh, sorry. This is Martin, the Practice Transformation Navigator for QBH. I was trying to get myself off of mute, but I couldn't. No, the QBH has done a really wonderful job with practice transformation, as you guys heard. The outcomes that they have, how they have implemented the Greater Columbia CARES model within the two sites that they have in Cohort 1 and Cohort 2. Whitney Bone, she has been a really important piece to this work, as she has, taken on this work and making sure that it's being implemented. And the one thing that really makes me happy is, hearing that they have shared care plans. They're collaborating with other organizations there in Clarkston. So that's just awesome, because that's one of the things that we want, as an ACH for participating organizations to collaborate with other organizations to enhance the work that they're doing and have the resources available that their patients need, and not be, well, we know you need this, but we don't have the resource. So that's awesome that they have been able to implement the Greater Columbia CARES model within their sites. And have had great success. And then, just one thing, Danica, that I'll mention, and Whitney, I don't know if you guys want me to, but I'll say it, is, one thing that they are doing, that, they're hoping to open a third site that will focus specifically on children in Clarkston, since, that's one of the gaps that they have identified, that there's really a need of behavioral health for kiddos down in that area of Clarkston. So they're going to be doing that hopefully here within the next few months. And the best thing is that they're going to be implementing the Greater Columbia CARES model within that site as well. So that's it's just awesome to see that this work has really benefited them, and that they're implementing it with in their other sites as well.
Thank you, Martine. Any final comments to the presentation by Danica about her organization, Quality Behavioral Health? All right. Well, hearing none, Danica, we didn't hold you over too long, I guess. I understand you've got a 10 o'clock appointment someplace. So thanks for spending a little extra time with us this morning, and congratulations on the good work of 2020, and may that continue in 2021.
Thank you very much for allowing it to happen.
Very good. All right, third up in this retrospective look at practice transformation sponsored by the Greater Columbia ACH in 2020 is somebody I think that those of you who have been coming to these Leadership Council meetings already know, Dr. Kevin Martin from Ellensburg. And Dr. Kevin is going to be talking about the Kittitas Valley Healthcare's experience with practice transformation. And I don't see anything up on my screen.
It's blank.
Chelsea?
It's blank.
So will there be something up on the screen?
There will be one slide.
One slide. Okay, Kevin.
Thank you for your support. As I was answering these questions, I realized that I've reached a point in my career where I can offer historical perspective. And when you ask what is the biggest accomplishment of the practice transformation program?
Well, to be honest with you, I totally spaced it.
Did you? Oh. I've been working around practice transformation for over 20 years, and so have people at what's now KBH. Back then it was Kittitas Valley Community Hospital. I first encountered the concepts of practice transformation in 1999 in the first Washington State Diabetes Breakthrough Collaborative. And our little private practice succeeded in proving that data collection and practice transformation was too heavy a lift for a small private practice on paper charts and spreadsheets. But it introduced me to people like Ed Wagner and Mike Heinmarsh. And when Mike Heinmarsh spoke to this group at our kickoff in Prosser, he was showing the same slides that I'd first seen in 1999, which I took as a measure of what meager progress we'd made. In 2005, I co-chaired the Washington Academy of Family Physicians Practice Transformation Work Group, along with Dr. Don Solberg. At that time, he was a partner at the Valley Clinic here in Ellensburg, and that group is now known as Kittitas Valley Healthcare Family Medicine Ellensburg. And while we were chairing that group, we saw the beginning of what is now called the patient-centered medical home, and those concepts kicked around. And we ran up against the same frustrations that I had in 1999, which we had an excellent model for primary care and no way to fund it. There was a summit in 2009 at Seattle Center where payers, employers, and providers got together and said, what should PCMH include? And it was unanimous that it had to include integrated behavioral health. And nobody could come up with a model to pay for it. And so that model has really thrived only in the setting of FQHCs. And in fact, the people who did the foundational work that led to integrated BH are still with Swedish. They were with, Jeff Ryder was at what's now Health Point in King County and at CHCW in Yakima. So it's a great idea that for 20 years, we've been unable to really make it work. Here at KVH, with GCACH support, we have successfully started behavioral health integration using the AIMS model at our Family Medicine Cle Elum Clinic, and we're fully staffed to that model. We started with the dyad of a lead physician and a psychiatric nurse practitioner who filled the psychiatric consultant role in the model. They had weekly huddles for case reviews and specifically identified a need to improve utilization of the GAD-7 and the PHQ-9. In April, we've completed the staffing by adding a licensed clinical social worker into the care manager role. That position was, we used ACH money to get that higher. Since April, she's had 52 patients, currently 40 active, and that number continues to grow. The team in Cle Elum has had enough success that the Ellensburg clinics have started to notice and are expressing interest in being next sites. As of now, 94% of the patients who've interacted with the BH team have a documented PHQ-9 or GAD-7. Throughout the organization, we now routinely give them at wellness visits or with any patient with known diagnosis or exhibiting symptoms of depression or anxiety. Positive PHQ-9 or 2 results in a suicide risk screening. We were also asked to address how we were impacted by COVID-19. And I had to think a minute to figure out what we meant by COVID-19. I know you're shocked, but it did have an impact on us. But the Cle Elum team was able to move to virtual visits early, and that's become a mainstay of their care. Going forward, as we recognize that a significant subset of our population struggles with mobility and access, and I'm looking out my window at a snow shower just to underscore it. Virtual visits will continue to be a useful tool in support of aging in place and the management of some chronic mental illness as long as it remains viable. Our direct involvement with the AIMS project ends in March, and so now our focus is on sustainability and spread. Another change that we implemented as part of practice transformation was widespread use of a medication reconciliation tool or shared decision-making tools. That was a new innovation last year when we started looking at medication adherence. Now at Medicare wellness visits, we routinely ask patients to fill out the tool. Probably the most useful question answered isn't what medications are taking, but why do they take it? And how do they feel about it? And it's interesting because my idea of why my patient is taking lisinopril may be very different than my patient's idea of why they're taking lisinopril. I did have one patient when asked, why are you taking the medication, wrote, because you told me to. which was a level of power I'm not used to in the exam room. We can quickly find out what their understanding is, whether they're willing to continue with it. We can consult with pharmacy and update it. We can look for, if cost is a barrier, we can explore that with pharmacy. And so that's been a powerful tool. And that can all be handled by pharmacy and nursing. What are the barriers? Well, the first barrier is probably the most obvious, but making change requires people to change, and nobody wants to change, and that's never going to change. We have to overcome that inertia anytime we want to make progress. We were fortunate that both our psychiatric provider and our lead physician in Cle Elum were trained in a setting where they had access to integrated BH, and they became our champions. The biggest barrier that we had organizationally was that before we had the support of GCACH and before we had Orrin O'Connell and Dr. Andy Thomas, no one in this organization had ever worked in integrated behavioral health. We'd heard it described, and many times we've tried to hire varying combinations of counselors, nurse practitioners, and psychologists and graft them onto a practice that may or may not have been ready to change. Now you can put up the slide. The result is like this. This was the first widely published image of the rhinoceros, and it was drawn by somebody who never actually saw a rhinoceros. They heard them described, they'd seen a sketch. The animal that this was based on was one of the first rhinos in Europe, and as it was being transported to Portugal, the ship was lost and the animal drowned. And it was 50 years before there was another rhinoceros in Europe. And I have a copy of this hanging on the wall in my office because this is how I think of our early efforts at integrated behavioral health. It reminds me of the dangers of trying to design something that you've not actually seen up close and studied. And our prior attempts at integrated BH were probably as accurate and effective as that rhino. What technical support from ACH and the organizational framework of the AIMS model offered us was an insight into how the rhino actually worked. It messes things up if you put armor plate and scales where they don't serve a function. There's more to integrated BH than a prescriber, although one is a valuable resource. But those were the insights that we simply lacked. And with Martine and the group, we were able to get some of that technical expertise that we really didn't have access to internally. How did you help through 2020? You got us over the hump. Without the support of ACH, I suspect we would still be struggling to bring about practice transformation. One of the things that you did was helped us to see that PC, patient-centered medical home, has application outside of primary care, and we're working to build those concepts into our inpatient service as well. The incentives that were provided allowed us to prioritize transformation and work to prioritize the work and deploy and recruit staff to support it. And while we missed the regular meetings with our facilitators most of the year, we still value the virtual support and encouragement that the organization has offered us. Top success stories. We are really seeing the integrated BH team take off. We haven't reached our goal of 60 to 80 caseload per FTE, but from a caseload of 10 in June, we had 40 active cases at year's end and another 12 who'd enrolled, improved, and discharged. So in addition to growing that number, the number of follow-up visits per active patient went from 3 per patient to 7 over the same period. So this is my opportunity to thank GCACH for letting me see and our organization achieve the first real success I've seen in practice transformation after 20 years of advocacy. There's still more work to be done. It's been said that anytime you pay for primary care by the encounter or the CPT code, you're failing. I distinctly remember telling my chief medical officer in 2012 that I thought we were only 3 years away from the death of CPT codes. You should not trust me for investment or betting advice. But we're moving towards it. We're moving towards models where we pay for care rather than for treatment. Models that when treatment is needed allow us to treat people and not conditions. Like I said, when I open, I'm at a point in my career where I get to reflect. And there have been many times when I despaired of ever seeing this kind of success. I'm thrilled at what we've accomplished, and I'm delighted by the partnership with ACH. Thank you.
Thank you, Dr. Martin. That was a great way to wrap up with that kind of a long-term perspective. Are there any questions of Dr. Kevin Martin and the Kittitas Valley healthcare experience with practice transformation?
Patrick, this is Carol, and I just wanted to thank Dr. Martin for being with Greater Columbia since the very beginning, spearheading one of the teams that we had to determine our project areas. Kevin, when you get to be as old as me, you can say that I'm an old dog learning new tricks. It's really nice though to hear that there's still opportunities for learning and expansion in primary care, and that you have really embraced this model and taken it to its full capacity. I don't know if people recognize in the annual report, we have a picture of your war room. That's what you used to call it. And so Greater Columbia just appreciates all the effort that KVH has made towards practice transformation, and we're really proud of watching your success and watching you embrace the integrated managed care. And just thank you for all the work that you guys have done to be so successful.
That was going to be a picture that I was going to use for a slide, and I went down to take a picture of it yesterday, and it's moved, and I couldn't find where all the charts were.
We'll send it to you.
So any other comments or questions of Dr. Martin?
I just have a, I'm sorry.
No, please go ahead.
This is Ronnie Batchelor. In listening to you, first off, bravo. It's an amazing thing that's happening. Where do you see this going within the next 5 years?
Hopefully, we can continue working towards models where, you know, it's kind of a cuss word in some circles, but the original concept of capitated care was that you get paid for caring for people, not necessarily for treating them. I think my other hope out of all of this work, and it's one of the things that ACH has spearheaded and really forced our community to come to grips with, is recognizing that all of the stuff that we do in our practices and our facilities and our programs probably only accounts for 20 or 30% of of the health of our communities. And I'm hoping that as we move to more, you know, in family medicine, we talk about the biopsychosocial model. You're treating the person that's in the exam room, but you remember the context that they're coming from. And if you start treating a bunch of kids for lead poisoning, you better figure out where it's coming from in the community. If you're treating a bunch of people for obesity, you better figure out why they can't walk and why they can't exercise. I'm hopeful that society will move towards that. In terms of healthcare, I think what we do in the exam room is going to be less provider-centric and more team-centric. And that really is the crux of PCMH, that if the reason that your health is falling apart is that you can't afford medication or that you don't have heat, I'm not the right person. We need to have you hooked up with a social worker. We need to have you hooked up with resources for secure housing. And I think that's going to be increasingly the emphasis of what goes on in practice.
All right. Spoken from somebody who has been in the trenches for as long as you have, Dr. Martin. Who is also talking there with, or posing a question with Rhonda?
This is Suzanne Swadner again, and I just want to follow along on Ronnie and Dr. Martin. You're illustrating for me what our goal is at the Healthcare Authority in looking at the evolution of the model. And Dr. Martin, I couldn't have paid you to say it more nicely. And that is that we are involving a model that's not just about what's in the exam room, but how we integrate with all the elements that Wes and Carol and their team have put together for this presentation. It's a great presentation because we're seeing all the elements. And one of the things that you're starting down the path to do, and you're a little further ahead, but this ACH is really forward thinking in this regard. It would be nice to think with you all a little bit about, as you ground and stabilize people in the current system, especially after the pandemic, how do we start to think about practice transformation in a cross-sectoral integrated way that Dr. Martin just explained really well, so that we can be doing projects to link the parts of the system and the members of the team that need to be linked. It would be interesting to think about how we do that work. It's going to kind of be, I believe, the next step for us in this work. So thank you. Again, great things for us to think about and talk about offline, not right now.
Thank you, Suzanne. And we have time for maybe one more comment or question from all of you online. Okay, well, you're off the hook for now, Dr. Martin, but the chat box is always there, and I'm sure that others may want to come and talk to you privately or offline. So we will now take a 10-minute break, and we'll come back. Yes, you got that right. We'll come back not at 10:30, but at 10:45 or 10:35, excuse me. And then we will look toward 2021 with a lot of people involved. So see you shortly, and enjoy your coffee break. Well, hello, everyone. I hope that most of you are back at your desks or in front of your phones or whatever device you're using to tune into this particular meeting. We like to stay on track here because we do want especially to hear from many of you about what you'd like to see in the Leadership Council meeting content for this coming year. So let's get started. And as you can note, Chelsea, can you put that can you put the agenda back on the screen? There you go. Okay, so what we thought it would be good to do right now is to share with you and to invite feedback to the goals that the ACH staff has identified for this year. And we are going to start with actually Chelsea and then move to Carol and then Wes. Sam is apparently not on the line today, so there'll be 3 little presentations from GCACH staff. All right, so Chelsea, the floor is yours about HMA and Associates and why we're talking about them.
Fabulous. Can everyone hear me okay?
We can.
All right. So welcome back from the break, everybody. We have a lot to look forward to for 2021 in this coming year. So one of the activities on our horizon for GCACH is our sustainability plan. So what are we going to do past the Medicaid transformation period? So to help us facilitate this really important work, we are working with Health Management Associates. And with that, I'd like to introduce Liz. Liz will be working with us directly. And Liz, are you on the line?
I am. Can you hear me? And I just shared my video, so hopefully you can see my face.
Yep.
If you want to, you don't have to see my face if you don't want to, but I feel like it's a little bit more personal. So hello, everyone. It's nice to be with you today. My name is Liz Argent, and I'm with Health Management Associates. Some of you are probably familiar with my organization. We did some work with y'all back in 2017 around the ACH applications to the state and just sort of helping getting organized and launching yourselves. So we're really excited to be back with you as the ACH looks towards what a sustainable path forward might be. So in addition to myself, there are a couple of other folks that are working on this project with me. Their names are probably going to be quite familiar to those who were involved in 2017. Kathy Homke, who is out of our New York office in Albany, and has actually been an interim executive director for a performing provider system in New York, which is sort of a cousin or sister to the ACH approach in New York. So she has a lot of experience exploring these types of issues. And Nicola Pinson, who did a lot of work back in 2017, helping get the ACH launched. So there's the 3 of us are the core team, and there's a couple of other folks who may or may not be involved. One is Karen Hill, who I know has done some work on practice transformation with some of you, and another colleague out of our Portland office, Michael Anderson Nathy, who is an expert in issues around health equity. So as Chelsea explained, we've been brought on board to help explore a sustainable path for GCACH, building on really just a lot of work that has been done by the board and staff already to identify some core competencies for GCACH and think about what that future might look like. And we, I think the main reason that Carol and Chelsea and the team wanted me to be here today was to just let you know a little bit about what we're going to be doing and that you may be hearing from us in the coming weeks, because our first step really in this process is to just verify a lot of the work that has been done by the board and staff to date around what those core competencies are and what interest there is in the community in what GCACH may be able to offer to the community. So we'll be doing a number of reach outs to folks in the community that have been identified by Greater Columbia. We're right now in the process of finalizing with the staff what that would look like, if it would be individual interviews, focus groups, surveys, and the questions that we'll be asking. So we're in the process of finalizing that right now, but I just wanted to say hello and let you know who I am when you start hearing from us. So yes, that's exactly why I'm here today. And with that, if there are any questions or comments, I have a few minutes, but I know you guys have a packed agenda. So Chelsea, Carol, anything?
No, thank you, Liz. We just wanted to put a name with the face. Sometimes it's a lot easier when people have had a warm handoff to make those introductions, and when some of our members or stakeholders or partners get contacted, they can remember, oh yeah, I remember this person talked to us at the Leadership Council meeting. So we wanted to thank you for making an introduction to you today, especially on behalf of the HMA team. And we look forward to working with you guys in the next few months and come out of it with a sustainability plan that we can all embrace and be confident that we have a future job with Greater Columbia ACH.
Great. Thank you all so much, and have a great day and stay safe, and I'll be in touch.
Thank you, Liz. Chelsea, do you have anything more to add in this section of the presentation?
Nope, that should do it.
All right. Well, then we will take the 2020 goal discussion or presentation and discussion in order. And Carol, you're back on tap, or is this something you, right? You're going to start, right?
I can kick us off, Patrick. However, this is Wes's main body of work. He has worked really hard to put this together, and this is just the project work streams, and he has assigned certain people to talk about certain sections so we can let everybody know kind of what's on our plate for 2021.
All right. So Wes, the floor is yours to explain this Technicolor graphic in front of us and help us unpack some of those diamonds we see. Wes, are you there?
Sorry, can you hear me now?
We can hear you.
I always forget there's two mutes on this. So if you've attended our Leadership Council meetings in the past, this diagram should look familiar to you, or it may look familiar to you. We've taken the major work that the organization takes on and separated it out into these horizontal lines, which are a time series. They go from January to November. And the blue diamonds that you see on each line represents a major milestone for each line of work. And rather than going through the whole diagram, what I'm going to do is point to some of our staff, including Diane, the navigators, Lauren, and maybe others to talk very briefly about some of these levels of work. And let me start with Diane. Diane, can you real quickly go through and talk about the learning collaboratives for the year?
Sure. Chelsea has put together a really good, handy flyer that we will be getting out to everybody, but it has all of the learning collaboratives and all of the leadership councils and those important meetings that we have. And so, yeah, so this is it right here. And so we have put together, we've put together a full year of learning collaboratives. And so we will be getting this information to everybody so everybody has it, but it will also be on our website as well as on our calendar on our website as well. But we are excited to launch our learning collaboratives this year. The learning collaboratives are focusing on the major items that are mandatory reporting items in the the Greater Columbia Cares model. And so that's what we're focusing on this year. So the next one actually will be on PCMH certification. And then we will have team steps, which is done by Karen Hill from HMA. So she will be doing it. And all of ours will be virtual this year and shorter duration. So they are not going to be as long as they have been in the past.
Diane, thanks for that overview. Let me point to Laurel. Laurel, you want to talk about the 3 cohorts and the Washington Rural Health Collaborative?
Yes. So our first cohort 1 group, we're depicting here in January. We've just finished up a reporting of milestones for year 2, quarter 4, and are in the process of reviewing those and responding to our partnering providers. The year 3 contracts are in process of everyone getting those signed and returned to us, and we've included in the Learning Collaborative information for everyone to understand what the year 3 requirements are for cohort 1. So we're also in the process of reviewing and redoing assessments as far as repeating the MEHAF and the PCMH assessments. And then soon to do will be the year 3 budget from our partnering providers in cohort 1. For cohort 2, they're mid-year and they're year 2 of practice transformation. They've just also completed their deliverable of their milestone reporting as of January 15th. And we're in process of reviewing that and getting feedback back to them. And then they just are continuing on with their practice transformation efforts. Cohort 3 just finished year 1 and are off to year 2. And we are in the process of getting all of their MEHAF and PCMHA assessments completed and new goals designed and documented for the upcoming year. So the diamond that says PTW on each cohort in the middle of February, that is an ongoing actually, but the practice transformation implementation work plan for each partnering provider is something that we discuss and work off of to guide our practice transformation efforts. For the Washington Rural Health Collaborative, I will point to Martine to give you an update in regards to describing the activities with that.
Thank you, Laurel. For the Washington Rural Health Collaborative, we have a contract with them to be working with some of the members, some sites that are members of that collaborative. For this work, we're focusing just on 3 measures that they're able to select, on which measures they want to be looking at, which they're diabetes, A1Cs, depression, and hypertension. So sites have the option, given, with COVID and, resources, being given to the response of COVID, the collaborative decided that, they could focus on 1, 2, or 3 of the measures. Here we have the timeline of the work that we're doing with them. So we started in 2020 working with them and introducing the sites to part of the Greater Columbia Cares model, since they're not implementing the whole thing. And here's the timeline of when the deliverables are going to be met. And this is actually, we had to push here the first time, and you guys see here year 1 Q2. This actually got pushed back to year 1 Q1, given that there were some setbacks with COVID. So this is actually the first time this month that they'll be reporting, and then we'll be working with them throughout the year in the different measures that they've selected to be focusing on. And we'll follow the same steps as the cohorts 1, 2, and 3. All of the collaborative sites are completing their MEHAP and PCMHs, and then we're also completing or continuing on with the practice transformation implementation work plan that documents, the progress that they have made through the work and throughout the quarters.
Laurel and Martine, thank you very much. The PTW review also represents the review by the Practice Transformation Work Group. That is the strategic advisory body to our organization. They quarterly review the results of the practice transformation work. Also on the timeline is a workflow for community paramedicine. We've put an estimated start for that particular project area and do have a budget line item to fund it. It's still under development, and kind of like some of the other organizations that we've entered into PCMH with, this too will be a matter of innovation for the organization and may actually set precedent for other EMS providers throughout the state. So we're excited about that and looking forward to that happening. Diane, I'm going to come back to you, and if you could please talk about briefly the ORNs, the CopeCom Care, and the CHW internship program, please.
Sure. So 2 of our opioid resource networks are continuing on into the 2nd year. Our Benton Franklin Walla Walla ORN, actually they're on a half year. So they have a half year left of their 2nd year, and they actually go through June. That we're continuing the funding for. And then Whitman just started their 2nd year of their ORN this year. And then CopeCom Care is our new community resilience campaign. And we are really excited. It actually is going to the board today, this afternoon, for approval and launch. So as soon as we get those done, and we present that, we're hoping to have that launched. It's actually already currently on our website if people wanted to kind of check it out. It's practicethepause.org, and I'm really excited about that, and there'll be more information to come for training, and we are excited about the training that will happen through Catholic Charities. They are the main person who has the contract to handle that as well. So we're really excited. It's evidence-based. We contracted with Dr. Kira Mouseth from Artemis, or I can never remember the name of her company. I feel so bad, but she actually is on the Department of Health strike team, behavioral health strike team as well. And she has put together just a really amazing way of dealing with this pandemic and this natural disaster. As for the community, so the next thing that I'm going to talk about is our community health worker internship program. So we're still in the process of developing this. So there'll be more to come on this, but we are in the process. We just developed a policy and an application that will be going to our board of directors. And this is really focusing on a community health worker internship program that is hoping to be based more out of our primary care sites. And integrating that community health worker within their organization, and so there'll be more information to come for that as well, and we will provide some online information about it, and we are doing it very similar to our behavioral health internship program. So it's very much done the way that it was done for that program.
Diane, thank you very much for that overview. I'm going to now go to Lauren. And Lauren, you want to talk a little bit about some of our remaining COVID-19 response activities and some of the LIN activities?
Yes, definitely. So at this time, and Wes's document shows this, at this time, we only have one COVID-19 related initiative, which is the Yakima Masking Communications Campaign, our round 2. It's currently running right now. It started at the beginning of January and it will end at the beginning of February. We're hoping to have some more efforts this year related to COVID-19, and I'm sure we will. We just aren't quite sure what that will look like at this time. And then in regards to the lens, so this really just shows the quarterly deliverables for our local health improvement networks over the course of 2021. You'll also see the Yakima Nation deliverables shown on this document as well. Something to note here is that we are reaching in 2021 to have, or I should say aiming in 2021 to have all local health improvement network contracts signed by February 1st.
Lauren, thank you very much. The final line on here, just above the business plan, is the Behavioral Health Internship Program, which began earlier, before 2021, and experienced a bit of a delay for some organizations because of the COVID-19 pandemic. However, that work continues. Organizations receive GCACH incentives to take on the responsibility of providing proctorship over individuals who are completing education requirements in the behavioral health field. There's a number of organizations that are involved, and there's quite a large budget to support that work. So the final report for that particular project area is scheduled for June of this year. So there's a lot of work here, and for a small shop of just under 12 people right now, this is quite an undertaking that keeps us all very, very busy. So does anybody have any questions about any of the work that's been outlined here? Okay, Patrick, back to you.
Nothing in the chat box. Let me just check here. This is, I think, a very, very good explanation of what is initially a little overwhelming graphic, Wes. And so I just, as the facilitator, I really appreciate this walkthrough, and I hope other people do, because you see that there are lots of balls in the air, and it looks like there are well thought out. Their trajectories as best as one can. There was a comment about outreach on COVID-19 vaccinations. So would any one of you like to just respond to that about what the ACH may do with sort of popularizing or publicizing that opportunity?
Patrick, this is Carol. I'd be happy to tackle that question. We are trying to work with the LHJs on getting some of that messaging out. Right now, I think that the communication has been mostly directed through the Department of Health down through the LHJs. But if there's any way that we can help the LHJs message the importance, especially in the harder to reach populations, we are on tap to do that. We're just waiting for maybe some invitations so that we don't trip over the LHJs in terms of communications. I know that they have a pretty strict communication plan, but we would embrace that work.
Okay, thank you, Carol. Any other questions of Wes or staff about this work plan for 2021? Okay. Before we leave this look forward, I don't know whether it's an appropriate moment right now, but we did bring this up, I think, at our November meeting, and I'll just pose it real quickly to Carol or perhaps Wes about what might happen beyond the right-hand side of this particular graphic. In other words, what might happen beyond November 2021. Is anybody prepared to sort of report out about what might happen after 2021?
Well, I can take part of that question, Patrick. So the Healthcare Authority is petitioning the Centers for Medicaid and Medicare for a 6th year for the Medicaid waiver, so that this was supposed to be the 5th year. We're asking for a 6th year. That will require legislation that will have to be passed by our Washington state legislators to allow funding that has already been set aside for the Medicaid transformation program to be utilized in 2022. So we're currently attending budget meetings and talking through with our legislators the great work that all of the ACHs are doing across the state of Washington, and hoping and crossing our fingers that we'll get that 6th year. So additionally, though, that is the purpose of the contract with Health Management Associates, to help us look beyond 2021 and 2022, so that we can be self-sustaining organization with our core competencies really in practice transformation, convening, and perhaps some workforce and training. So we're looking forward to working with the HMA to better define what that future looks like, and the marketing that we can do to get the word out about our competencies.
Very good.
So,
yes, Wes.
Yeah, just to add possibly one little other piece here. So since the beginning of this endeavor, we've emphasized the importance of care coordination and technologies to support that. And the ACH continues to look at options that are available in the marketplace, and options that might be stood up in the marketplace to support community-based care coordination. So there may be some additional work tied to that particular area. I won't go into details at this time, that might be implemented either this year or perhaps next year. So stay tuned for that.
Okay, thank you, Wes. Are any reaction to what you just heard from Carol or from Wes for folks on the line about not only 2021, but 2022 and beyond? I know that we'll have more opportunities to discuss this in the future, but I think what I'm trying to convey to all of you is that this doesn't appear that as you go to the right-hand side of this graph, that this will be the sunset of Greater Columbia ACH.
Patrick, I should also add that we are working with Dan Vizzini. I noticed that he was on the line earlier, who has been doing modeling cash flows for us, and we're looking pretty good through 2023 in order to be able to provide additional support to our provider organizations. So we think that if we could get this year 6 funding, that would really propel our efforts into 2023 and give maybe a couple of more years of practice transformation to some of our provider organizations.
Wonderful, wonderful. Okay. Suzanne, if you're still on the line from HCA, can I put you on the spot, or would you like to take a pass on that question? Maybe not on the line anymore. All right, well, let's move into the final section of our meeting, and this is basically asking you what you would like to see from this 2 to 2.5 hour period once a month, more or less, and how it might be helpful to your particular institutions or organizations. Staff actually meets at least a couple times before every leadership council meeting and tries to make this as well thought out a program as possible. And then there's also subsequent work from those meetings just to line up our speakers and to make sure that this is going to fit with a lot of different dimensions on the ACH's activities. So we have some ideas, but before any of those ideas sort of hit the print button, we wanted to hear from you. So these have been typically, leadership council meetings have been typically open-ended. There's no great number of limiting parameters. It's just basically, the question is what will help the organizations that participate in the ACH. So to do that, we have brought out the tried and true Mentimeter, which I think will be there on the board. And so as you can see, we invite your participation by going to that URL, using the code 842122, and just start throwing up some suggestions, which then everyone can take a peek at. So if you wouldn't mind pulling out that computer in your pocket or your purse and getting started with that, we'd appreciate it. Just looking at the calendar, we won't have 12 opportunities for a Leadership Council topic choice, because first of all, we're already in one of the 12 today. And then as for those of you who have been with us a while, you know that we typically take off the month of December, and we typically take off a meeting in the summer. So basically that is 9 Leadership Council meetings that we would like to organize. And that could drop a little further to 8 if we pursue what we've done in the last 2 years, which is to have the LINTs report out in a fall meeting. So I think we're basically looking at filling 8 months worth of invigorating and hopefully informing presentations and conversations with all of you. So that's what we'd like to get your feedback on. And if you wouldn't mind just starting, let those things that are sort of front and center of your mind pop up. Okay, so there's the first one. Wes or Diane, would you like to add anything further about your take on Leadership Council meetings?
I don't at this time. I think we're trying to keep this this question pretty open-ended to gather feedback from our partners and stakeholders to see what direction that they want to take this body. As Patrick talked about, these types of convenings were pretty popular among the ACHs and have dropped off somewhat as some of the other ACHs have become entrenched in particular project work. But it's always been our mission to support feedback from all of you attending.
One of the things I just wanted to bring up is that for the learning collaboratives, we're really focusing on learning from each other. And so I think, you know, even with the Leadership Council, that's really something that could be utilized a lot, is that we want to hear how you're doing, how you're implementing things, how things are going. And I think that like as today's meeting, I think that it was a great success. And I think that other organizations like to see how things are done in different ways. And so that's one of the things Sam and I have worked on with the learning collaboratives, is really focusing them on learning from each other.
Okay, thank you, Diane. Carol, any quick comments from you about Leadership Council meetings and how they fit into the Greater Columbia big scheme of things and how they may fit into the state landscape?
It's interesting, Patrick, because the community, the Leadership Council was really an idea born at the very beginning, modeled after the Benton Franklin Community Health Alliance that Kirk Williamson currently manages. So they have a board of directors that make the day-to-day decisions, month-to-month plan for strategically. But then the Leadership Council is really important body of work, is to, because you're in the community, you know the issues that you're being faced with. It's really to get feedback from the community members about what's going on in the healthcare delivery system. So we're just really interested in learning more about the challenges or the barriers or the successes that our partner organizations are having and how we can work more closely together. A network in and of itself is a model for action. As we get together and we get to know each other's work, we can combine forces, collaborate. And so for Greater Columbia, it's an opportunity for us to understand how can we work more closely together and more collaboratively together.
Thank you, Carol. Thank you. Wonderful. Thank you all for being so creative now and starting to have those creative juices flow to put up some good ideas for Leadership Council meetings. I'm going to briefly just ask, we've got 20 minutes left on if you could just stay with us over the next 20 minutes. For those people who had proposed a couple of ideas, just to give a 1 minute or less sort of explanation of why they proposed that. So let's start at the top left-hand side. And the first one that popped up was change leadership. So if you could bring that back down, I think, there you go, Chelsea, change leadership training. And there was a clarification about how this will motivate, what can be done to motivate staff towards change leadership. So whoever proposed that, would you mind just popping up and saying why you think this is a good idea? Anybody?
Sorry, I was muted. This is actually Brittany. I'm one of the practice transformation navigators, and I wanted to bring this up in here because this is something that I've heard from a lot of my clinics, that sometimes they're struggling with bringing the change that is needed into it. So that's something that has been asked, so I wanted to bring that out. That's more for trying to get the staff motivated. I know there's a lot of staff burnout due to COVID-19, and so the struggle this year of trying to keep people motivated and interested in the practice transformation efforts with everything that's been going on.
Okay. Yeah, thank you. Yeah, I'm sure that's a big concern for anybody on the line who's in charge of operations. Okay, going to the next one, left to right, highlight area providers. I don't know if that means a whole lot of explanation, but whoever proposed that, do you have any further comments?
This is Kendra Colomore from Coordinated Care. It is just incredibly useful to see, other models and, the resilience and everything that's occurring, to get up-to-date information on, exactly what providers are up to, how they're doing it. It's just really, really helpful in understanding what's going on and what gaps in services are out there and what's needed. So I very much appreciate it.
Great. Well, thank you. There are definitely successes that need to be both celebrated and certainly learned from. Okay, going again further left to right, we have support for infrastructure, the social determinants of health. Need to maybe cover that. Would anybody like to comment further on that one?
That was me. I think we've done kind of like what I said in my remarks earlier. I think we've done a great job of improving how we deliver healthcare. But going back to the early documents, that when we're talking about community impact back in the very, very beginning, we acknowledge that that's a small piece of the puzzle. And I think that's where we could have lasting impact.
Great. Yeah, thank you, Dr. Martin. Okay, second row, looking at COVID-19. We've already heard that COVID-19 has affected staff and morale and potentially led to higher rates of burnout. Would anybody like to elaborate on that particular suggestion?
Yeah, this is Lauren with Greater Columbia. I actually recommended this topic. I know that in 2020, our Leadership Council planning team did a really great job bringing up topics that kind of hit close to home. In regards to COVID-19, we talked about self-care in overwhelming times, right when COVID-19 kind of started. And so once we hit that recovery phase, what does that look like? What's that going to look like? Just kind of helping our providers and our Leadership Council audience, recover and get to that recovery phase. I also think this could be a good time to maybe highlight our Cope Calm Care campaign and the tools that we've provided through that campaign. So a couple of different topics I think that we could maybe include in just one COVID-19 Leadership Council meeting.
Okay, well, thank you, Lauren. And should that happen, we want you to tune in from wherever you are. Okay, let's look at the one in the middle here, the some sort of a panel on community health workers, and then get some knowledge about how the ACH's efforts in behavioral health internships are working. Would somebody like to comment on that one?
This definitely
Patrick,
will.
that would.
Yeah, I was going to say. Go ahead, Carol.
No, I was just going to say that was mine, but I really think that as we move forward with this internship program, it'd be very helpful to bring in community health workers, figure out, you know, where we can have the most impact. I think we've been a little bit criticized because we have such a focus with our primary care behavioral health system, and we know that we need to branch out into more social determinants of health. So understanding more about how we can integrate them into the work that we're doing to support the work that Dr. Martin is doing would be really helpful.
Okay, thank you, Carol. Okay, continuing on in the third row on the left-hand side, we've sort of covered this a little bit, but somebody would like to quickly elaborate intersection of social determinants of health with COVID impacts on community services. Anybody?
Yeah, this is Matthew from Lutheran Community Services, and I think you said it already. We pretty much covered that. It was just, and I second what Dr. Martin was saying, and just that this is something that we're going to be trying to figure out for a time, and I think us having conversations is really the best way for us to learn from one another.
Great. Okay. So we've heard that more or less twice so far. This is, I think, somewhat similar to the one we talked about, highlighting area providers, celebrating the work that's being done. Would somebody like to comment on that if there is any further comment?
Okay, I'll admit, I was going to put more parties like I did last time, but this is Diane again. I do think it's really important that we celebrate all the work that you guys are doing. I cannot stress how much we are so proud of every organization that we work with. And I really want to emphasize how important all of your guys' impacts to your communities that you're making. And so that's probably why I put this, but I really do want to celebrate all of you and all your hard work.
Okay, well, thank you, Diane. Why don't we cursor down a little bit, Chelsea, and let's see what the next row looks like. Can you cursor down?
Oh, good question. Hang on, let me go back. Sorry.
We're not done quite yet. I saw a few more pop up there. Okay.
Lauren, do you know how it lets me scroll down without being?
Try to click on where it says 11.
That's what I was doing.
Yeah.
You might have to go back into the presentation mode, and you can click on one by one so it shows result layout. Oh, you can, I think you can still scroll down here if it lets you. If not, you can go back to that screen, Chelsea, and you can click how it's displaying the results before you go into presentation mode.
Bear with me, everybody. Thank you.
So see the result layout down there?
Yeah, I'll just do one by one.
You might have more.
Okay.
There we go.
Stop right there. This is a new one. Would anybody like to comment on this technical but very important topic about value-based payment contracting? We've had a couple sessions on that over the last 2 years. But we know it's still a pretty daunting task to wrap our arms around. Anybody want to comment on this one?
This is Laurel, that one of the practice transformation navigators. That was actually mine, and I thought it might be nice to have a presentation from the MCOs on the most important outcome measures that they would like to see presented from the organizations that are looking to contract. Just a really basic measure set and maybe an explanation of why that's important. So there could be some conversation back and forth between our partnering providers and the MCOs. That was my idea.
All right. Thank you, Laurel. That will certainly be considered. Next one. Okay, so we've sort of heard this already, how providers are doing or organizations more generally in the practice transformation projects. Would anybody, is something more to add to this one? Okay, why don't we go to the next one, Chelsea? More parties. Well, yes. Yes. Are these going to be online parties or are these going to be over at Carol Moser's house? Next one.
I think
Yes.
what I missed, I think it's missing the in-person stuff. I really hope we get back to that. That's what I'm really hoping.
Right. Well, let's hope all your efforts in the 9 counties get to some very high rates of vaccinations, and we'll be in phase 4 here in no time. Next one, please. Is that it? No, there are a couple more. Is that it then, Chelsea?
Yes, I think that's it. I'm scrolling up to make sure there wasn't any we missed. Looks like that's it. Oh, we have one from Dan in the comment box, how the MCOs define value proposition for CHWs in partnership with CBOs or clinical partners.
Okay, yeah, so kind of an amendment to or clarification to that second to the last one we had. All right, so we're sure that's it for all the suggestions. Good way to end. More parties. So I would venture to say, and Diane and Wes can confirm or unconfirm this statement that many of your suggestions are the ones that staff has actually considered. So that's nice to see that overlap. And we will get together and be talking about this real soon because we do need to plan for our February meeting, and we have nothing on the books yet. So stay tuned on that one. And I just wanted to thank you all for tuning in on this winter day, hopefully not too snowy in your neck of the woods, not even here in Spokane, and invite any last minute comments from Carol.
I just wanted to say thank you for everybody for joining and for your comments regarding future meetings, and hopefully you'll be back in February.
All right. Well, with that, go forth. Let's all go forth and do good works. And we will see you at the February meeting, Thursday, the 18th. Take care.
Thank you.
Thank you.